This webinar series today is brought to you by SafMed. SafMed is your solutions partner in both the CSSD and operating room environment. I'd actually like to take this opportunity to wish SafMed happy birthday. Because SafMed turns 35 years old this year, so thank you, SafMed. Well done. The SafMed journey, of course, started focusing in the world of CSSD, but has expanded into the operating room. And with that expansion, of course, we have gained a huge amount of knowledge and growth in the operating room environment. And today's webinar series is focusing, of course, on surgical. So this is our first webinar for 2023 with a surgical focus. Please feel free to share your knowledge about our webinars and, of course, our surgical webinars with your operating room colleagues. We have also shared with the APSA team, so hopefully they will also forward the information to them, because there's lots of surgical related information that we're going to learn today. Obviously, many people, both in the operating room and the CSSD environment, aren't often able to attend live webinars. We have all sorts of things that crop up, like work or load shedding or strange bits and pieces like that. So as normal, we are recording our session today, and links to the video recordings will be available. Staying abreast with what is happening in our field requires a hell of a lot of dedication, a hell of a lot of work and input from all of us. And of course, well, it took me 7 years to do a BA Kerr degree in health service management, nursing education, all done part-time while I was a scrub sister. So I'd get up at 3:45 every morning, study for an hour, and be at work ready for my list starting at 7. And that's how we get on with life. We put some effort and energy into learning. So that's the nice value add of having the links to these types of webinars. We can view them at a time that suits us. So today's focus is on rigid endoscopy. And when it comes to endoscopy, we need to remind ourselves of some of the terminology. What is endoscopy? Of course, endoscopy is really looking into a cavity. We can look into and operate inside a number of areas of the body, including a joint, for example, a knee, inside the uterus, inside the bladder, inside an ankle, inside a wrist, and of course inside the abdomen. Non-medical people often refer to the term, of course, keyhole surgery, and this type of approach is also referred to as minimally invasive surgery, or MIS. There's a really nice abstract from the ARN journal that was published in 2019 that I think really sums up some of my beliefs around MIS surgery. And it's true that in the past 20 to 30 years, MIS has become commonplace in almost all surgical specialities now. And the needs of the perioperative team and the patients, of course, differ quite a lot versus traditional open surgery. The equipment and the instrumentation required is extensive, and it continues to evolve as new techniques are developed and new instruments are found and developed as well. Perioperative nurses are challenged to stay current on all the available technology and the results of the research so that they can provide safe patient care. And that's what we're here today to do, to update all of our knowledge around endoscopy. Well, I'm very sure a lot of you know that there are a multitude of benefits to MIS surgical techniques and approaches, and that includes less pain, fewer wound infections, reduced hospital stay, reduced morbidity and mortality, an earlier return to work, and an overall improved quality of life for the patient. What will we cover in this webinar series? We've got 2 webinars, one today, one in a week's time, same place, same time. Today, we're going to go into a bit more detail on the equipment needed to perform MIS. We'll look at the technology and how we get the image quality that we need, how some of these items are made. We'll touch on laparoscopic instruments themselves. We'll look at quite a few of the risks associated with MIS surgery, especially around electrocautery, or hernia as we know it, as well as a bit on ergonomics. Next week, we'll take an ever deeper look into all the risks associated with MIS. We'll look at patient positioning and the importance of correct patient positioning. We've got a very nice guide, a troubleshooting guide from the Society of American Gastrointestinal Endoscopic Surgeons, otherwise known as SAGES. We will review that. And then there's some interesting work coming out of the AORN and SAGES that combined have come up with MIS safety checklists. Is that something we should be doing as a standard practice in our operating rooms? Have we heard of these checklists? Maybe it's something we need to incorporate in the future. And we'll delve into those in webinar 2. Starting off by reminding ourselves of the technology and the equipment that we need. Of course, the basic components are going to include a telescope, a light guide cable, a light source, and then, of course, the light source via the light guide cable provides light to the telescope itself. On the other end, on the eyepiece, connects the camera head. The camera head then takes the picture to the CCU. CCU is connected to the monitor where the image is displayed. In order to visualize the internal structures, we need some form of media, like irrigation fluid or gas, to distend the area that we need to get into. Of course, we'll use insufflator with CO2 in laparoscopic surgery. Over and above that, we need a whole lot of accessories like ferries, needles, trocars, surgical instruments, surgical irrigation, diathermal electrocautery, lasers, and all sorts of suturing materials and bits and bobs to get along with our surgery. The camera head, so the clarity of the image that's eventually displayed is going to depend on a multitude of things. Of course, including the telescope itself, whether the telescope is warm, whether there's fogging in the abdomen, if the telescope is dry and clean, the connection between the telescope and the camera head, the technology of the camera head, and the resolution capability of the monitor. Doesn't help. We go through all the effort of getting all the fancy technology, and then we don't buy the correct type of monitor for the type of surgery that we're doing or for the technology that we're using. The function of the camera control unit is to capture and process the video signals that are received from the telescope and the camera head, put that on display on the video monitor to give you accurate visualization of the operative field. The camera unit, of course, is attached to the camera head in the front console, and at the back normally is all the connections to the video monitor. The digital cables connect to the monitor from the CCU to the monitor using two particular formats. You can use a DVI, which is a digital video interface, or an SDI cable system, which is a serial digital interface. The resolution capability of the monitor, as we said earlier, should match that of the video camera. Always safe and correct practice to use a proper surgical monitor, not a monitor you use for your laptop at home, and not a monitor something you use for gaming or for watching television. Surgical monitors are what we need, both from a safety perspective and of course they are purpose designed to give you the best visual display for that type of surgery. So there's lots of technology and a whole bunch of terminology around the image that is displayed. And of course, the main advantage, or certainly one of the main advantages of laparoscopic surgery, is the enhanced appreciation of the intraoperative anatomy through the use of magnifying optics with high definition properties. That's one of the great value adds, is being able to see. So what technology is used so that we can get a good vision? There's all sorts of terms that you may come across, like CMOS. And CMOS is a sensor that electronically, is an electronic chip, and it converts photons to electrons for digital processing. You'll hear words like SD, standard definition, HD, high definition, and these days, of course, 4K. There's another technology out there that you may not have heard of before, and that's called CMOS with Sony Exmor-R technology. And that technology reverses the location of the receiving photodiodes and places them directly after the lenses. This type of technology, with it, you get no loss of signal when you're crossing over the sensor. And that type of technology will give you better field of depth of field, can give you a brighter image in poorer light conditions, a nice value add to have, and it gives you a better appreciation of the volume of the cavity. At the end of the day, of course, all manufacturers are trying to give you the best image quality, bearing in mind the cost, bearing in mind the technology, and as time goes by, updating what it is they can with all of this great technology as it becomes available. There are two common types of telescopes, rod lens type telescopes, and then digital scopes using camera chips in the tip of the rigid or the flexible endoscope. I have a lot more experience using rod lens systems, and I have less experience using a digital camera telescope. The fiber optic light cable, of course, it reflects light. Light enters through one end of the fiber, passes through a whole lot of internal reflections, and eventually comes out the other end of the fiber. Fiber optic light cables have very high quality of optical transmission, but they are fragile. The light source of itself, of course, is critical to the visualization of the operative field. If there's no light, we can't see, and in these cavities, it's pretty dark. And if we're doing stuff in the cavity like cauterizing or there's blood or anything of the sort, it becomes harder and harder to see. So we've moved over the years from halogen to more xenon-based light sources, and of course nowadays we have LED technologies. LED light sources generate less heat, and they generally are more energy efficient. A colleague shared a video, a link to a video that's on YouTube that is really quite nice, and it shows the manufacturer of both the telescope or rod lens telescope and light guide cables. It's really quite useful. It's a very short video, but something you might want to learn from. If so, let me know. I'll give you the link to it. It is in the bottom of the slide. The manufacturing process for a light guide cable is going to start with making these little bundles of fiber optics, which is really fine glass. Once the bundles are now bundled together, and it's really fine work, I felt quite sorry for the ladies and the people trying to do this job. It was quite difficult and requires quite a bit of dexterity. Little bundles are gathered together at the right thickness, and then they are fed into the silicone outer lining. The two ends are connected, as you can see in the picture displayed, and it finishes off with a sanding process, it seems, to round off everything and give you the correct tip and edge that you need for your light guide cable. Very delicate work. I'm sure many of you already know that the care and handling of the light guide cable is very important. It is fragile. Those little fibers can break quite easily. When the fibers break, then of course you lose light. You need to avoid squeezing, stretching, or bending the cable. When you insert the light guide cable into the light source, always remember to hold onto the actual connector piece and not the cable itself. Don't tug on the cable directly when you're trying to remove it. Always work via the connector piece. Avoid puncturing the cable, especially with towel clips when you're securing the cable to your drapes. Do not turn the light source on before connecting the light guide cable to the telescope, because you could end up with a fire. We'll talk about that in a second. Inspect the cable for broken fibers before each use. Your supplier, I'm sure, will be able to teach you how to do that by applying light to the one end and looking for the little black dots. Those black dots will designate parts where the fiber is damaged. If the percentage of the number of breaks is really big, obviously you're going to need to replace your cable. Cleaning of the fiber optic cable is very important. Keeping the ends, the reflective ends, properly polished and cleaned is just as important as normal. You're going to remove debris and organic materials using enzymatic detergents, and of course, following the instructions for use from the manufacturer. Rod lens telescopes, as I said, here's some images from that video. They are made up of two main aspects. If you can look at the round circle over there, you can see the little arrow reflecting the light fibers. and then the objective assembly. So the objective assembly is the little place where all the little glass rods get put in together into the outer metal casing. There are things called spacers in between all of them. And then on the very outside is a whole lot of those fiber bundles again. So the telescope itself, both the rod lenses and, of course, the fiber bundles are very, very delicate, and we need to look after them carefully. As you know, I should think with some of the terminology, the eyepiece, body, the light post. You can see over there the objective assembly, and of course, very importantly, the field of view and the angle of view. And telescopes come in different angles, as you know, providing you with a 0 degree, a 30 degree, a 40 degree, a 45 degree, or 70 degree, for example. Looking after these telescopes, maintaining them, is really a tricky business. Really nice publication in the Journal of Society of Laparoscopic and Robotic Surgeons. This particular one talks to principles and safety measures for electrosurgery and laparoscopy. We'll talk to this document a few times today, but first we'll start with the discussion around thermal injuries as a result of fiber optic cables. So, of course, as we know, we said we need a reliable light source to get adequate visualization, but thermal damage can actually occur as well. If the light source is exposed, the tip of the light source is exposed to your surgical drapes, it's quite possible that the drapes will char within 3 to 6 seconds. Now, as a scrub sister, I scrub for a multitude of endoscopic surgery, mostly around gynecology, and I can assure you I've burnt at least 4 drapes in my time. Sometimes it takes me time to learn things, so it can really and truly be quite a big danger. You can see over there that injury was recorded with the optical cable 3 millimeters from the skin. You can end up with superficial tissue necrosis as well, aside from the linen catching fire. All problematic. I wonder if an LED light source will reduce that risk. I would think so, seeing as the heat generated from them is a little less. Also important to be aware of the flammability and the sources of fuel in the operating room for potential for fire. Fire is near and dear to my heart because I have experienced a few, not only on the terms of drapes, but where surgeons using cautery and patient was not properly dried after prep, patient caught fire. Not a pleasant experience and really not nice for the patient at all. So to reduce the risk of surgical fires, we need to be aware of the common fuel sources. We need to be aware of the fact that the higher the oxygen is in the environment, which of course it is quite a bit in the operating room, we have problems of great potential for fires. As you can see over there, the blue cotton towels, pretty flammable, can be flammable, as well as abdominal swabs, they're also very flammable. But be careful if you're trying to do your white balance and don't put a swab up against the light guide cable, especially if it's not connected to the telescope. Again, coming back to the principles and safety of electrosurgery and laparoscopic surgery, injury from inadvertent energy transfer has been reported as between 1 to 5 recognized injuries per 1,000 cases. That is quite risky, isn't it? I'm not sure I like those statistics. Here are some terms you may not have heard of before. And this journal article describes the different types of electrothermal injuries in endoscopic surgery specifically now I'm talking about. There is the type of injury that can result of direct application. So that's when there's unintended activation of an electrosurgical probe. Maybe you're busy working on something and you accidentally end up standing on the pedal, and you activate and you burn a piece of tissue that you were not aiming at, or got some part that's moving and you accidentally catch that. It wasn't where you intended to be. Direct coupling, so that's a little bit different. That's when the unit is accidentally activated while the active electrode, okay, so the tip of the diathermy at this point, is in close proximity to another metal instrument. And there the patient ends up burning via the second metal instrument. Insulation failure, that may be one you know well because it happens not only in laparoscopic instruments but in a lot of other devices as well, where the insulation coat actually becomes defective and something that we need to worry about. Then there's capacitive coupling, and that was a new one for me to learn, although I've experienced this again as a scrub sister, and this is where electrical current is actually transferred from the active electrode through the insulation into adjacent conductive materials like bowel. So that's without direct contact. You can end up burning bowel, you can end up burning ureters, and that's where my experience lies in damaging ureters with lateral thermal damage. The patients became extremely ill, and it's often not caught at the time that it actually happens. Now, insulation failure is the main cause of laparoscopic electrosurgical injuries, and of course it's associated with an instrument that is used repeatedly. Because of that repeated using, you have breakdown of some form of the insulation that is on the outside or coats the actual instrument. By lowering the concentration of current used, the risk of accidental burns can actually be reduced. 18% of the insulation defects are along the instrument in an area that's outside of the view of the monitor, but distal to the protective cannula of the port itself. And as you know, while you're doing the laparoscopic surgery, we're focusing on the tips of the instrument. We don't necessarily see the whole of the instrument, and it's possible that there's a little insulation failure, and you think you're diathermizing just at the tip, and in the end, you're burning something further up the chain that you can't actually see. Approximately 75% of these injuries are also unrecognized at the time of occurrence, which of course is great risk for the patient. There was a nice question in the ALN journal posted in 2020. The question was, we bundle all of our cords together, including the monopolar active electrode cord, the light cord, the camera cord, when we secure everything to the drapes for laparoscopic procedures. Is this practice recommended? And very quickly, the answer is no. The monopolar active electrode, the dithermic cord, should not be bundled parallel to the other cords. The reason for that is that you have the potential or an increased risk of unintended thermal injury now from a phenomenon known as antenna coupling. So a new word for me. So with this particular phenomenon, antenna coupling, it occurs when there's a stray bit of energy from an energized cable, like from the monopolar active electrode, i.e. the dithermy, that can escape, and it can transfer to a non-electronic energized cord. And that in turn can result in injury both to the patient and of course to your equipment that is potentially right next to it. So very important not to bundle everything together. Right, as we spoke about earlier, we need an insufflator. And an insufflator, as you know, is used to create a pneumoperitoneum in laparoscopic surgery. The creation and the maintenance of that pneumoperitoneum is really important in laparoscopic surgery. Of course, it's essential. If there's no pneumoperitoneum, the abdomen collapses down, you won't be able to see. It can be life-threatening if it happens at the wrong time. If you're in the middle of something crucial, you could end up damaging some anatomy. It can honestly be a terrible set of circumstances if you aren't able to maintain pneumoperitoneum. The most used intubation gas is carbon dioxide, CO2 as we know it. The reason for that is because it's cheap, it's got low toxicity, it's easily reabsorbed, and it has a low risk of gas embolism, and thankfully it's non-explosive. Of course, we want insufflator systems that can alarm if the abdominal pressure exceeds the predetermined level, because high pressures are very, very dangerous. They can lead to hypercarbia, acidosis, hemodynamic and pulmonary terrible side effects. We'll carry on with more risks associated with high pressures and insufflation in webinar 2. Running out of CO2 can be life-threatening. Pneumoperitoneum is created using different techniques. There's blunt techniques, there's sharp techniques, there's techniques using Very's needle, of course. And what can be a really useful feature in an insufflator is if the insufflator has the ability to display the amount of time that's actually left in the CO2 bottle. So how long that bottle you're using can last for your next procedure, so that hopefully you can know when to change the bottle before you start the next operation, so you don't end up with the risk of not maintaining the pneumoperitoneum. We often use diathermy, electrocautery, of course, the correct terminology during laparoscopic surgery. That surgical plume that's created can create all sorts of issues. Firstly, it can fog our vision, so we can't see what's going on. And over and above that, it can raise the intra-abdominal pressure for the patient, again putting the patient at risk, as we had said. Some insufflators might have the capacity to automatically exhaust some of the gas, which is, again, a very nice feature to have. But when you have that feature, what you don't want is the gas actually going back into the insufflator itself and contaminating the insufflator. So it makes sense if that surgical plume's gas is actually exhausted into the atmosphere instead of actually into the insufflator itself. Now, of course, the thing to worry about is surgical plume or smoke plume. There is a ton of research and publication on this matter, and I think it's a whole entity unto itself, and one that we haven't grasped yet or taken up well in the South African setting. In America, it is now quite a huge occupational health issue, that of exposure of theatre staff to surgical plume and the ways that we should manage it, including the use of smoke evacuation systems. Of course, the smoke and the plume, the surgical plume, can contain toxic gases. It contains vapors such as benzene, hydrogen cyanide, formaldehyde, and of course then these bioaerosols, dead and live cellular material, and viruses. So, this kind of thing puts us at risk. So if you're using an insufflator, it really is a useful thing if you have something that's got a filter attached to it, and that would be really something that protects both the machine and hopefully the staff as well. Sometimes we will use fluid. We can use fluid media as a distension or for irrigation, obviously now depending on what body part you're working with or what cavity. It's often used in cavities like the bladder or inside joints as a distension media and for irrigation. We can install fluids using an infusion pump. We can install them using gravity, and that gravity we can use a pressure bag with or without a pressure. Use of fluids, of course, comes with its own potential complications, and it includes extravasation and intravasation. With intravasation, the irrigation fluid is absorbed into the patient's bloodstream. That absorption is commonly referred to as the transurethral resection syndrome, because that's when it was first noted, was in the transurethral resection procedures. When you absorb too much of the fluid at the end of the day via your vasculature, it can cause hyponatremia, hypervolemia, and of course cardio and pulmonary complications, and this can be life-threatening. To do that, to worry about that or to prevent that occurring, of course, there are a number of things that we can do, including observing for a decreased core body temperature, hemodynamic instability, and abdominal distension, and hopefully your anesthetist is on board and keeping an eye out for all these things. Very nice article, again in the ARN journal, on descending media used for hysteroscopies. And it goes on to describe the fact that during hysteroscopy, a surgeon uses a descending media to create a working space to view inside the usual cavity. The media can include carbon dioxide or electrolytic or non-electrolytic fluids. Carbon dioxide is mainly used in diagnostic hysteroscopies. However, it may cause more pain. And it also creates a risk for gas embolism. I've not personally used carbon dioxide in hysteroscopes. I've only used fluid media for that type of procedure. The amount of absorption of distension media is going to be related to a number of things, and that includes how much the surgeon has disrupted the integrity of the venous sinuses in the endometrium and in the myometrium during surgery, obviously, the size and number of lesions that have been removed, the depth of the resection itself, and the number of myometrial sinuses that are exposed, including, of course, the intrauterine pressure. All of these things at the end of the day are going to affect the potential for fluid absorption and that potential for a life-threatening risk on the patient. Varying the height of the bag can affect the infusion pressure, and the higher the distended media is actually placed will, of course, make the potential risk even worse for the patient. Operative hysteroscopies involving large tissue resections that last longer than 60 minutes tend to lead, or more likely to lead, to these fluid overload events. So lots of things to think about when it comes to risk of laparoscopic surgery. Moving on to chat about laparoscopic instruments. So we're covering a huge amount of information in this particular video webinar. Of course, the correct selection and proper use of laparoscopic instruments is vital for the safe performance of the laparoscopic surgery. Tissue dissection can be a bit more challenging versus open surgery because of the lack of what is known as haptic feedback. So haptic feedback is really that feel, that force field that you can feel with your hands. So you know how hard to push or pull or dissect or press. With laparoscopic surgery, of course, you're only getting that feel, but you're getting that interaction all the way down this long shaft. And because of that long shaft, it actually eliminates some of those tactile cues and it masks the forces. So you may end up pressing too hard, not realizing how hard you're pressing because you don't really know, because you don't feel it the same. So that takes a bit of time for the surgeons to get used to in laparoscopic surgery. Scissors can often be used for sharp dissection, or of course you can use energy devices if you're expecting tissues to bleed. As I said, that's going to create fumes. Plumes are going to create intra-abdominal pressure. All have their own pros and cons. Counter-tip devices can be used to open up tissue planes, and suction devices or laparoscopic pledgets can be used to create tissue. Well, you all know, and the ARN reminds us again, that all instruments should be cleaned and decontaminated as soon as possible after use, and that preparation should begin at the point of use, which means that scrub staff have a responsibility to play in managing the instruments themselves. We all know that blood, organic material, debris, and saline are corrosive to instruments. We know that we need to remove gross soiling and we need to keep our instruments moist by preparing them in some format for transport till such time as they get to the CSSD where we can clean them properly. So we in theatre play an important role in preventing issues with our instruments by starting to disassemble them, by preventing drying on them. And one of the ways, of course, we can do that is using transport gels and foams. In some countries, they go so far as to use these very fancy technologies. I wonder if we'll ever get to use them one day in our setting. They've got a thing called like a duck bag, I think is one of the terms. It's a bag that's pre-impregnated and it's a humidified environment. So they're big bags, obviously come in different sizes, depending on the size of the instrument that you're using. You take your laparoscopic instruments and you shove them all in this bag, close it up and send them off down to CSST. In some of the other surgeries, especially I've seen it more in robotic type surgeries, robotic instruments, are these little tip soaker thingies. So it's a vial with some fluid in it, with a flange in the top, and you actually put the instrument into this flange, and it automatically now soaks the instrument in the small amount of liquid in the vial, and the vial flange sort of closes over the instrument so there's no spillage. Very interesting types of methods of managing things. Nice textbook, an ebook on mastering laparoscopic and thoracic surgery, interesting manual published now in 2023. It talks to, a little section talks on cleaning, disinfection, and sterilization of laparoscopic instruments. It goes on to state, which I think is a really important point we must remember, that laparoscopic instruments are one of the toughest challenges to all of us to process. They've got extremely difficult to clean long shafts. They've got complex, small, tiny jaws on them often that can trap a hell of a lot of infectious bioburden and debris. Then you have to think about the fact that the positive pressure of the CO2 in the insufflated abdomen can also cause blood and other body fluids to flow up the channels, making it quite difficult to remove. So very difficult to manage these instruments. So they go on to talk about the importance of using automated cleaning devices with port and lumen flushes. That, of course, can include your ultrasonic cleaner. If you're using an ultrasonic cleaner, it is going to help, of course, to use one that's got a lumen flush and not just irrigation on the outside, because you want to be able to flush and irrigate and put ultrasonics down the lumens, because these lumens are particularly difficult to clean. Or in some cases, of course, you can use a special rack inside your washer disinfector, your automated washer disinfector, that also has the ability to attach to the ports of your laparoscopic instruments. So not just lying them flat in a washer disinfector, very specific racks that are designed for that type of instrumentation. Remembering, of course, that telescopes like guide cables do not go in ultrasonic cleaners. Right. As normal, I'm always going to look at how contaminated our surgical instruments become, and there is well-known published data on bacterial contamination of surgical instruments. This published paper comes out of, it says they're a resource-limited country. When you read further, you note that all of the authors are from Ghana, so I'm assuming they're referring to Ghana in this. In this instance, they took 207 instruments after they had been sterilized from some different theatres, including urology and general theatre, and randomly sampled them for bacterial contamination, and they actually identified what type of bacteria it was. A lot of the bacteria, by the way, were bacillus related. If you look at this table over here, where the first, of course, lists the instruments themselves. Then it talks the number of instruments that were tested. It tells you the actual bacteria that was isolated and which number of those instruments were actually positive. So if you can see over here, let's take the gallipots. Can you believe it? 2 out of 6 gallipots were positive for bacteria. That's really sad. Mayo, scissors, some of them, 2 out of 8, indeed. Right, focusing, of course, of endoscopy, because that's our focus point for today's webinar. 3 out of 9 shoulder arthroscopes, so that's the actual telescope itself, tested positive for bacteria. Going to urology, all sorts of instruments, dilators, tested positive for bacillus and staphylococci. The urethrotome, cystoscopy bridge. The bridge is quite a complicated device, I think, not that easy to clean. So 2 out of 5 of those bridges were positive. 3 out of 7 of the urethotomes. The Bridget telescopes themselves for cystoscopes, the 30 degree and the 0 degree. How's that? 3 out of 9 of the 30 degree and 1 out of 7 of the Bridget cystoscopes tested positive. Wow, that's scary, isn't it? Of course, as you know, bacillus species have the potential to contribute to surgical site infections. Scary. Right, closing off with the last topic of today's webinar, and that's going to be focusing on ergonomics. A significant number of laparoscopic surgeons suffer from work-related musculoskeletal injuries, as much as up to 70% of them. And they go on to state that ergonomics is really more pertinent to laparoscopic surgery than probably open surgery or even robotic surgery. Incredible. I scrubbed for urology quite a bit, and I must say at the time, in the beginning, the guy that we worked with was still going with, sticking your eye to the telescope lens, and he ended up with terrible neck issues. It really is problematic. Fatigue amongst the surgeon and the assistant, and I think us as well, may increase the risk of error during the procedure. Hence, every effort should be made to improve the ergonomics. So what can we do to improve those ergonomics? Well, let's first understand the terminology. It's derived from the Greek word ergon and nomos. I'm sure I'm not pronouncing that correctly, but of course it pertains to a scientific study of people at work in terms of equipment design, workplace layout, working environment, safety, productivity, and training. If you look at the image on the right, it refers to an ideal surgeon stance, so the ideal monitor and table height during laparoscopy. I'll describe that now in a minute or two. Another thing in ergonomics I worry a little bit about is fatigue, and I've seen some published papers talking to the fact that should we not be using anti-fatigue mats? Should we not be standing on these types of mats to keep ourselves safer, to prevent fatigue for those jobs of ours that require lots of standing? So the position of the monitor is going to depend on the size of the screen being used. Ideally, the monitor should be between 90 to 200 centimeters away from the surgeon in a straight line, but that facilitates the surgeon's gaze being a little bit downwards. Okay. So obviously, to be able to achieve that, you've got to have the patient that's correctly positioned. You've got to have an operating table that can go up and down in the heights that you need. We have to take into account the height of the surgeon. You might have the capability or capacity to mount everything on monitors or mount everything on pendants, which would make it quite nice, especially if there are pendants that you can lift the height up and down on. If it's a mobile unit, so in some cases, in some facilities, we are still using mobile units, especially in some of the smaller facilities that the mobile unit needs to go from theatre to theatre. In that case, the trolley that you buy, the trolley setup that you have, remember to make sure that the arm that holds the monitor is height adjustable. You have to take that into account. If you're doing ENT, you might need to be, obviously, the patient's lying down, the surgeon might be seated. You need to be able to move that monitor around. So be careful when you're thinking about that you have the ability to move the monitor. It's not only about ergonomics, of course, it's also about being able to operate correctly. Next point to raise is where the laparoscopic instrument handle should be. That sounds weird, but again, you need the operating table that's adjusted to the surgeon's height and position, so that at the end of the day, the laparoscopic instruments are slightly below the level of the surgeon's elbow. And the elbows should always be flexed at around 90 to 120 degrees. How's that for interesting? Wonder if you knew that. And then this one I found particularly interesting as well, is that the instrument should be inserted as such that at least half of the instrument is inside the patient. If less than half of the instrument is actually inserted inside the endoscopic wall, it creates excessive motion on the shoulders of the surgeon, and that is likely to fatigue the surgeon sooner. So although these ergonomics matter to the comfort of the surgeon, they also matter at the end of the day when it comes to the safety. A comfortable surgeon is a safer surgeon. So, very important topics. What did we cover today? Well, we looked at a little bit more detail on the equipment and the instrumentation that we need for MIS. We've looked a little bit about how it's made, and we've discussed some of the important care and handling. We've delved into some of the technology and the technology involved in good quality imaging. We've discussed some of the risks associated with distension media and electrocautery. We've discussed the importance of good economics. I know economics would matter too in MIS, minimal invasive surgery. Thank you so much for attending today. As normal, we'll be sending out a link with a short survey and a few questions and test questions. If you complete the tests, we will provide you with a certificate of attendance. Next week, same time, same place, we will cover rigid endoscopy part 2. We look forward to seeing you. We'll send out the invite to that webinar perhaps a little bit later today or first thing tomorrow. And in that one, we'll go into a lot more detail around risk. We'll talk a little bit more about the value add of adjusting the brightness, the gain, those kind of settings on your camera head or your CCUs, and what the value add is all of that. We'll look at patient positioning, as I said, and we'll also talk about surgical safety checklists specific to laparoscopic surgery and a little bit on troubleshooting. Thank you for joining us today and look forward to seeing you next time. Bye. Cheers.